Thank you very much. So my French is not so good. I'll speak English. Sorry for that. Thank you very much for the invitation. I'm very happy to be here in this beautiful country and very honored to give a talk on arrhythmic mitral valve complex. So we've learned a lot about the Barlow valve and we've seen some cases of arrhythmia. But for now, we're going to, let me see how this works. There you go. And this works as well. Perfect. So I start with a case, 40-year-old male, exertional dyspnea, no chest pain, no risk factors, and he came to the cardiology practice for an echo. And this was the echocardiogram. And you can see something's wrong with the mitral valve. There was no left ventricular dilation yet, not yet. Eccentric regurgitation, severe. What would you do? These are the short axis images. And the question is, what would you tell the patient? Would you do a repeat echo? Would you do an MRI? Would you do nothing? Wait. Who says we're going to wait? No wait. Operation? Maybe. Exercise test? Yeah. Okay. I agree. So nothing happened here. Patient went home, and then 6 months after, patient come back again with an out-of-hospital cardiac arrest. We did a TOE because he was on intensive care unit, and it was similar as 6 months before. Because I do MRI or ERM, I did an MRI, and it's more or less the same as an echo, just different, but actually it gives the same results. You can see that there is mitral valve prolapse, but you can also see there's a little bit rim here, over here, mitral annular disjunction, which we will speak about today. We did some fibrosis assessment, and there was no fibrosis, no late GAT, and there's a little bit of twisting of the left ventricle. We call it curling. I'll come back to that later. So we've learned about mitral valve prolapse. I'm going to skip this one. More than 2 millimeters systolic displacement. You got the classic primary myxomatous mitral valve prolapse and the non-classic secondary one. It's associated with sudden death. We don't know actually why or how, but we do know that it happens. And then we have the second part, which is mitral annular disjunction. And I'm going to speak about the definition in the next slide. There's a relation between sudden death, between mitral valve prolapse, maybe Barlow, but it's not very entirely clear. And if you look at mitral valve, mitral annular disjunction, you have to be careful that it's sometimes pseudo disjunction and sometimes real. This is pseudo, and this is real. So the real mitral annular disjunction really has a cleavage or a space between the mitral annulus and the myocardium. And if you look at that with echocardiography, sometimes it's very hard. But now with the new techniques, with CT, with MRI, you see it a lot more often. And it starts people to question, is that a sign for sudden cardiac death? What do we need to do? And then there's a second thing, and it's called systolic curling of the posterior wall of the myocardium. And it gives you the vision of a ballerina shoe, and it comes in a little bit hypertrophied of the posterolateral wall, and that might also be something that is related to the prolapse and to mitral annular disjunction. So we're going to speak about this for the next 10 minutes. So if you look at the mitral annulus, we should know that it's not really an annular. It's not a ring. There's very many different shapes within the myocardium and in every single heart. Sometimes it's very clear, like here, where there is the myocardial wall, the annulus, and then the atrial wall. But sometimes it's a mess, and it looks different. And the myocardium interferes with the annulus. So it's not really a continuous ring where the mitral valve is within. Okay, so it's a fibrous-like structure, and it is a structure between the atrial and ventricular myocardium. And if you look at the movement of the mitral valve, if there's no mitral annular disjunction, what happens between systole is that the myocardium will pull the mitral valve towards the apex, and there will be a deep settle type of the mitral valve. And the deep settle type of the mitral valve will give you a good functioning mitral valve. You can understand if there is a gap between the annulus and the myocardium, and then the myocardium pulls the mitral valve towards the apex, the valve will go outside the heart. It will move the opposite way. And what happens then is that you get an unsettling, so you don't have a settle. And you can understand that the shape of the mitral valve will be more flat instead of a settle. And if it's flat like that, you can imagine that the insufficiency or the regurgitation will be worse. So for the patient, it's worse. So we know that the mitral annular disjunction is associated with worse insufficient mitral valves. Then second, we have to know that we as cardiologists, we have a funny thing with the heart. We have funny names for the heart. We call it the anterior valve, we call it the posterior valve. But if you look at the heart, the valve is not anterior. And the other valve, the posterior one, is not posterior. So the anatomists, like Professor Anderson, Bob always told me, don't call it anterior, don't call, you fool. It is the mural valve leaflet, and it's the aortic leaflet. That's how you should name it. And if you look at the heart, there should be a supralateral commissure, and there should be an infralateral commissure, not with posterior or anterior. That's totally incorrect. And if you look at your annulus, if you call it, it's not an annulus. It's just a structure that keeps the mitral valve in place. So he said, the thing that you feel is related to sudden death, like the mitral annular disjunction, is okay. It's safe. Well, is that the case? So we looked at the literature. We went back all the way up to 1876. That was the first time that MAD was described by the anatomist, Professor Henley. And then in 1981, there was the first case that a young doctor had sudden death at young age. And if they looked at the mitral valve, besides prolapse, there was also mitral annular disjunction. Somewhat later on, Dr. Carmo and colleagues looked at it and they said, well, it's related to arrhythmia, be careful. And then Cristina Basso looked at the histology and she said, well, if there is mitral annular disjunction, there's more fibrosis in the myocardium. So maybe, yes, it can be related to sudden death. And then her colleague, Perazzolo, she also looked at it and said, well, there's more late enhancement, more fibrosis, if there's more MAD. And then this paper came out. And this paper is very important because this is the first paper that taught us mitral annular disjunction is related to sudden cardiac death. They took 116 patients, looked at mitral annular disjunction, and they related it to the Holter findings with ventricular ectopies, but also ventricular tachycardia. And in this paper, they said, there's a lot of people with mitral valve prolapse, and some have arrhythmia, and some don't have arrhythmia. But if you look at MAD, that is proportionally related to sudden death and arrhythmia. So this was the paper that everyone was like, oh yeah, what do we need to do now? So every cardiography report mentioned there's MAD, and every MRI report there is MAD, and every CT report there's MAD, and everyone starts to shake. So we did a second analysis. We looked at all the old MRIs, and then we looked at the UK biobank, and in a huge biobank of about more than 2,500 people, normal people like we are here, I guess, we saw that 76% of the people have MAD. That's a huge number. But the infralateral one, if it's close to the posterior or the mural leaflet, that doesn't happen that much. Okay? That only happens in 5%. And if it happens, there's more prolapse and more curling. So now we're getting somewhere. Then we looked at a proportion of patients with idiopathic ventricular fibrillation, and we also saw that there was more MAD, more mitral valve prolapse in those patients. increasing the number of patients. These are 185 patients. We also saw that there's more MAD locations if there was more sudden death. And then the algorithm started, because they said, what should we do with those patients? If everyone has MAD, and some people say it's normal, and some people say it's abnormal, how do we going to cope with this? And this study beautifully explains, also using artificial intelligence, that the way going to arrhythmia is not following the path of MAD, but it's following the path of fibrosis here and related to curling. Curling, mitral valve prolapse, fibrosis, and mitral and disjunction. Those are the four cornerstones that you have to pay attention to. And then the question is, if we do operate those patients, like my patient with the out-of-hospital cardiac arrest, if I correct the valve and I take out mitral and disjunction, is then everything solved? Do I need an ICD in these patients? Well, this study beautifully shows that even if you operate on all those patients with mitral valve prolapse and you correct the mitral valve again and you take out all the MAD, then still patients that had MAD before have a threefold increase of ventricular arrhythmia afterwards. So an operation doesn't heal arrhythmia in patients that had before arrhythmia and mitral and disjunction and prolapse. So this one you can't read. This is a first algorithm from the guidelines for the ERA that explained what you should do with patients with MAD. I think it's not very easy because everything ends up with people giving an ICD. So that's a little bit tricky. What's good to know is what is ventricular arrhythmia. What is important? You have three different classifications. One is PVCs more than 5%, or maybe some VT runs that are slow. But the most important ones are VT runs around 180 or more, and sustained VT or ventricular fibrillation. Those are the most important ventricular arrhythmia, as you can imagine. Our EACVI Society proposed another algorithm because the EACVI said, well, many people don't have MRI. So if you want to risk stratify those patients, how should you do that? Well, start with echo, look at the mitral valve, look at curling, and do strain, as we've just learned as well. If strain is impaired, the reason may be that it is due to fibrosis, because strain and fibrosis are closely related. And then you look at your Holter findings, exercise testing, and you can do your risk assessment. Finally, a wrap-up from the American College of Cardiology. They do more or less the same. I think the most important difference here is that you should look at other substrates for arrhythmia, because if they have another disease, if you do genetic testing, for example, there's another reason for arrhythmia. So don't focus on the mitral valve alone. So to wrap up, I'll just end with another patient. It's a 40-year-old woman. She had palpitations. This is her EKG. I think we will do an echo with these symptoms. And this is her echo. You can see there's a little bit of MAD. There's mitral valve prolapse. We did an MRI, of course. There's no fibrosis. There is curling. There's mitral valve prolapse. Tiny bit of MAD. It was 5 millimeters. So what should we do? I think, again, Holter monitoring. So we looked at the Holter, and this is what you get. So do we give this woman a defibrillator? Who says yes? A few. And who says no? This is okay. It's tough. So after this talk, I tried to teach you what to do with mitral and disjunction. And you just have to remember, MAD is not rare. I guess that the majority of the people here also have MAD. Inflorescent MAD can be associated with arrhythmia, but pay attention to the mitral valve, curling, fibrosis, and other issues. And the MAD itself is just a small risk modifier of the whole model. Well, thank you so much, and we hope to see you at the end of the year.